This is like a potpourri of talks, y'all. We're covering a spectrum here, which is at least fun for me. I'm not bored yet. All right. So switching gears now, I'm going to talk a little bit about alcohol withdrawal. I'm going to talk a little bit about identifying alcohol withdrawal, about treating it, and then figuring out why did the patient go into alcohol withdrawal. This is pretty much what you need to do when you see it. And the first step is identifying alcohol withdrawal. So I think sometimes it's very apparent. A patient will come in and say, I'm withdrawing, look at me. And sometimes it's more insidious. A patient will come in maybe for something else. Maybe they're there for medical reason, chest pain or shortness of breath or some cellulitis. And then you notice, what do you notice? Well, we see that maybe they're getting a little anxious. They're getting diaphoretic. Is it their chest pain? Is this their acute coronary syndrome? Or is it something else? And then they get this sort of sympathomimetic surge, tachycardia, fine tremor. Their blood pressure can start creeping up and then they can get hypertensive. So oftentimes we see these patients looking a little more anxious, a little more diaphoretic, a little more tachycardic. Sometimes we know from the outset it's alcohol withdrawal. And as I mentioned, sometimes it kind of catches us off guard and we have to think, could this actually be alcohol withdrawal? Sometimes then it progresses a bit. People can get agitated. They can get this coarse tremor. So you start off, it's a little more subtle, fine tremor, some tachycardia. Their sympathetic system is increasing and increasing to the point where they become agitated. And then sometimes they can become downright wild. They can get hallucinations, seizures, hyperthermia. And I'm saying all of these things and I'm repeating it because I think it's really important that we think about it, not only in the patients who we know that they drink a lot, but in patients who we don't know. The first time it ever caught me off guard, I was a resident and we couldn't figure out what was going on with this guy. And it turns out once we thought about it and started treating him, he got lucid enough to tell us once we sort of kicked his wife out of the room that he drank a lot. Wife had no idea. He hid the liquor bottles in the air conditioning vents. And so again, sometimes it's obvious, sometimes it's not so much. But this is what we want to avoid, and this is why we need to identify it. And so we can kind of think about alcohol withdrawal in time since the last drink, which is on the horizontal axis here, and how severe the symptoms are. Because alcohol withdrawal often starts off and it's not that dangerous, it's not that severe. And so what often happens, it can be even early on, a couple hours since the last drink. You can get this sort of general mild withdrawal, often characterized by like this hyperactivity. So like the sympathetic things, the diaphoresis, a little bit of tachycardia, a little bit of a tremor, and that can last a couple days. What we really want to watch out for are seizures. So seizures, about 40% have isolated seizures, and it's the first sign of delirium tremens in a decent number of patients. So we want to avoid seizures, if at all possible, but they can still happen early on, a little after the onset of general withdrawal. But this often depends on how much a patient drinks. And then the hallucinosis. So people can have sort of this transient hallucinations. They can be tactile or visual. And then oftentimes people have this clear sensorium. They'll just be hallucinating some. And this is different than delirium tremens, in which they don't have that clear sensorium. In delirium tremens is the really dangerous thing. And that happens a little bit later. So first, general withdrawal. Seizures can happen pretty early on. It doesn't have to be a ways. They can happen out 24, 48 hours. Patients can start to get the hallucinations after about a day or so without a drink. And then delirium tremens happens as sort of a later consequence when they start to get really altered as well. And that's about 2 days after the last drink. And these are sort of general approximations. Patients can differ, but often it's sort of this type of progression. And so when you identify, how do you characterize it? Is it mild, is it moderate, severe? There are different scoring systems that can be used. I don't know if y'all use any of these. For example, at our shop, we use the CWA score, and it basically ranks a lot of those symptoms. It's this big, long checklist, and the nurses do it, and they'll tally it up. But oftentimes you can look at a patient, you can get a sense. Are they vomiting? Do they have tremors? Do they have sweats? Are they really anxious? Are they agitated? Are they hallucinating? Are they delirious? And this can help you figure out, is it just mild withdrawal, a little moderate touch, or is it really severe? And this is helpful in sort of gauging. And again, when I'm deciding whether to treat a patient with alcohol withdrawal, I don't tally this up. I kind of use my bedside evaluation of a patient, but this is one way to kind of gauge over time, is the patient improving or not? All right. Y'all have a patient. You are seeing them. They have some alcohol withdrawal. I'm really curious. What do y'all use? What is your drug of choice for the treatment of alcohol withdrawal? You can drop it in the chat, or you can unmute yourself. I'm curious. Or no drugs. No. Okay, there we go. I was going to say you don't treat alcohol withdrawal. Benzos, Phenobarb if you're in the ICU. Love it. Valium. All right. Yeah, I love this because there's a lot of a practice pattern variation around how people treat things. It's one of my interests in terms of research. So I love just figuring out, what do people use? Great. Yeah. So you have this patient, they're anxious, they're sweaty, they have a little bit of tremor. When I first started practicing, when I was a resident, benzo, typically Ativan. It was easy. People, a milligram of Ativan, 2 milligrams of Ativan, lorazepam. But what happened was we'd give them a milligram or 2, and then we would give them more, and then they would need more, and then they would need more. And once we gave 98, I'm not proud of this, 98 milligrams of a benzo to a patient with acute withdrawal. That was a lot. They probably had some PCP or something on board too. But what happened is oftentimes that's a little too little and a little too late. So oftentimes we dose lorazepam in these small dosages. It sounds like y'all are a little more evolved there. I thought I was too. So I started using diazepam. So 10 milligrams of diazepam, and then I would need more, and then I would need more, and then I would need more. The truth is, there was this 2020 study done. It was a retrospective observational study, but there's probably no big difference between benzos. I find diazepam is a little easier to dose, or in terms of we actually tend to dose appropriate dosages, versus anecdotally, people give small doses of lorazepam, which probably doesn't touch the drinkers quite as quickly. I have a couple issues with benzos though, and I'm going to be clear. This is my bias. This is a very biased talk. Usually I'm pretty objective when I talk. I'm really biased here. I think with a lot of benzodiazepines, we give too little and we give it too late. So there's some issues here, and it's time to reevaluation. When I work in the emergency department, I have started setting reminders on my watch, my Apple Watch, and my phone, because I will think 30 minutes has passed. But what's really happened is a trauma has gone in. I've gone to the trauma, a stroke alert has come in, and a STEMI. And then so by the time I actually cycle back to the patient, it feels like 30 minutes, but it may have been an hour and a half. So when I'm thinking about a therapy I want for a patient, I want something that's really going to tackle them head first. So I don't have to go back and reevaluate and stay on top of it. And that gets to the frequency of dosing. Again, if I need to dose something really frequently, if a nurse needs to reevaluate and dose frequently, it often turns out that when it requires that frequent reassessment and dosing, that again, we end up dragging our heels and getting a little bit far behind because we're busy in the emergency department. There are a lot of patients. That's a lot of bedside power. And then oftentimes we sort of underestimate the dose. We think it's a touch of withdrawal, but it takes a bit of time for the drug to work. And then once it starts working, we end up needing more, and we need more. We may underestimate what we need in order to treat the patient, because they may sort of go off that cliff of starting to withdraw more and more severe a little quickly. There are also some side effects to benzodiazepines. So respiratory depression is one. Oftentimes with the doses that we give and people who really are sort of lacking that GABA agonism, we don't really see that a lot, but it's a possibility. Sedation as well, although that's sort of what we're aiming for in a lot of these sort of hyper amped up patients. The big one is delirium. When you give a lot of benzos and you give them for a long period of time, you can get delirious. There are also things like secondary games. Sometimes patients will come in and they will really want these things, even if they're not in withdrawal. So there are options. The field of treating alcohol withdrawal has evolved. So we now have what's old is new again. So phenobarb has really come back in as a player for the treatment of alcohol withdrawal. Of course, there are benzos. Our menu now includes ketamine as well. And then some of you may have heard of the use of dexmedetomidine. It's sort of popular in a lot of sedation for patients who are mechanically ventilated, but also as being used in alcohol withdrawal. So we're going to talk about these a little bit. And I told you that I'm a little biased here. So from the forefront, I'm going to be clear. I think phenobarbital has superior pharmacology to the others, to the benzos, to ketamine, to dexmedetomidine. And I like it because I can use it first line, no matter how severe a patient is withdrawing. And then I don't have to keep changing up agents. So if somebody just has a little touch of withdrawal, maybe they're there for something else, and I'm thinking about being able to discharge them home, I can give them phenobarbital. If they have moderate or severe withdrawal, I can give them phenobarbital. I don't have to think about it. I'm a simple person. I want something that's easy and that I don't have to think too much about and sort of take that cognitive load off. The other thing is that ketamine and dexmedetomidine, they are merely adjuncts. People get excited about them, but they're really adjuncts to a benzo first type of algorithm. And so they're really for use in refractory withdrawal that the benzos just aren't touching adequately. All right. I said phenobarbital has superior pharmacology, but I am a methodologist. I believe in EBM, so we're going to talk about why. So we've got to talk a little bit about pharmacology here. So alcohol withdrawal, one of the big things that happens, and we were all taught, is basically you don't have enough GABA on board, and as a result, you have less inhibition, which means you're sort of amped up. What we're taught less about is you have sort of too much glutamate. You get this upregulated excitatory NMDA receptors. So you've got not enough GABA, you got too much glutamate, and it means you're sort of hyped up and getting a little wild. That's a simplified version of alcohol withdrawal, sort of what's going on. Now, benzos, they do increase your GABA. So they increase the frequency of the opening of that GABA channel, which is great. It treats part of the problem, part of the issue with alcohol withdrawal, which is you don't have enough GABA. Benzos will get you that GABA. They will open that person's channels and it will help treat the problem. But there are a couple things with alcohol withdrawal. There's not only the GABA, but also the glutamate. Phenobarbital happens to work on both of these neurotransmitters. So it prolongs the opening of those GABA channels, but also works to decrease glutamate. And we talked about how the NMDA receptors that glutamate is the neurotransmitter are upregulated. So this will help decrease that. So it targets both aspects for alcohol withdrawal. Ketamine, it only works on the glutamate. So in case you've never used ketamine, it's a drip. So you don't just bolus ketamine. You start them on a drip, pretty low doses, 0.2 to 1.6 mg per kg per hour of it. And so it works on glutamate, but really it just decreases the benzo use. It doesn't fully treat alcohol withdrawal because it doesn't have that GABA agonism that you need. Same thing with dexmedetomidine. It works on your alpha-2 receptors. So it works to decrease those sympathetic responses, which basically treats some of the symptoms, but it doesn't really treat the problem. It helps, again, like ketamine, decrease the benzodiazepines. So if we're looking at these and we have phenobarb, GABA and glutamate, benzos, just GABA, ketamine, just glutamate, and dexmedetomidine, alpha-2, no GABA, no glutamate. And we're just talking about pharmacology, phenobarbital emerges the winner. Now, we're talking about duration of action and how long things work. Phenobarbital also has a superior duration of action. It lasts for a longer period of time. The time to max level, sure, it doesn't work as quickly. And I'm going to be honest about that. It doesn't work as quickly as things like lorazepam or diazepam, onset of action in just a couple of minutes. Time to max level, if you're giving it IV, 15 to 30 minutes. Orally, it's 30 plus a little bit of minutes. So if I'm giving somebody a load IV, if I'm giving them a push, I'll tell the nurse, check back on them in 20 minutes, redose them if they need to be. So it takes a little bit longer to work than the benzodiazepine, but the half-life is for days. So it's not that you have these super high levels, but that you will retain some on board for longer periods of time so that it just doesn't all fall off at one period of time. That also means you don't need to taper. So a lot of places, the idea is you give them something and then you give them a taper of chloridized epoxide to go home with or something like that, or you taper them in the hospital. But here with phenobarbital, you don't need to taper them down off like you do with benzos. Another thing is that because it lasts for longer, you have a longer dosing interval. So it's not like you have to go back to the bedside every 10, 15, 30 minutes. Is once you load them or once you give a couple of pushes, depending on how severe, and we'll get into that, you don't have to keep going back. Obviously, you want to reassess your patients, but it's not something that you have to keep dosing, keep dosing, keep dosing. You can get control up front and then retain that control. The other thing that I like about phenobarbital is that it's titratable to severity. So you have a patient who just comes in, they're a little bit anxious, they've got some diaphoresis, tachycardia, fine little tremor, says, doc, I just have a little bit of withdrawal. I'm trying to get in to a detox clinic soon or something. Phenobarbital is great for mild withdrawal. You can give it IV. You can give 260 milligrams as an IV push. That's not a high dose by any means, or you can give it PO. You can give 90, 100, 120. Sometimes it comes in like 30 milligram increments. Sometimes it comes in 100, depending on what you have on formulary. But you can give it IV or PO depending on whether a patient's like nauseated, tolerating oral intake, those sorts of things. But it's great for mild withdrawal, and you can give it either way. So I like it for that reason, because I've got a dose, I can give it to a patient, evaluate the response, and redose if needed. The other thing is that then if there's somebody that's a candidate for outpatient, they can be discharged, follow up. Maybe they were just there for something medical, they're going to go back home. We can discharge them without a taper if that you might need if you're doing benzos. It's also safe. So there's been this concern that like phenobarbital, it's what we use to put people in comas. Sure, if they're on a drip and if you give them super large doses. Here, we're not talking about those doses, and it's not a problem if they go home and drink, because it's not like they're going to keep mounting the phenobarbital in their system. It's going to slowly degrade and become less and less and less. So you're not obscuring sort of in creating a setup here for respiratory depression in these small doses. So if they're agitated, that's if they're mild withdrawal. Now, if they're agitated, they've got that coarse tremor. If they're hallucinating, have seizures, hyperthermia, obviously like treat their seizures, et cetera. But phenobarbital is great in severe withdrawal. And here, if I see somebody that's pretty sick, I just bolus them right up front, 10 mgs per kg. So often I'll start at like 700 because we presume everybody's like 70 kilos. I'm not sure why, but I'll about estimate a patient's weight and just bolus them that. And then I can give them some pushes if I still need control. But here, I'm just giving them a bolus. It's really easy to sort of run in. And then we go to a max of 20 mgs per kg. And that is because after that point, it's unlikely to work. It's probably that there's something else going on. It's not just simple alcohol withdrawal. It's probably an infection that sent them into alcohol withdrawal, or a head bleed or something else. And you need to be reconsidering your differential at that time. Now, some places have looked at patients who have delirium tremens, and they start with IV pushes. And then once a patient can take oral intake, they transition them to oral phenobarbital as needed while they're in the hospital. And what they found is this is like insanely cheap algorithm to do it this way. And so it's actually pretty cheap to do it. And so you can start IV and then transition to PO as well, although that probably has more influence on the inpatient side of things and not on sort of what we do in the emergency department. But just to say that you can mix and match, but also if you're interested in pricing, oral phenobarbital is cheaper if you're looking at cost effectiveness. Phenobarbital, so it's got great duration, that's great. It's got the pharmacology theoretically is more ideal, but does it actually work? So if you were to line up phenobarbital versus a benzo, what do we find? So this is a study where they took phenobarbital, this was done in California. They took phenobarbital and they gave 260 milligram IV push, and then they gave 130 milligrams as needed to control the withdrawal, versus Ativan, they gave 2 milligram IV pushes as needed, and then they discharged with this chloridized epoxide or delirium taper. And they wanted to know what happened to the CWES scores. So did it control withdrawal? Yeah, like the scores, it dropped the scores very well. And by 48 hours, patients both had like decreased CWES scores that were appropriate. And so the issue here is that with one, you're having to discharge a patient with medication that they may or may not be able to get, that they may or may not take appropriately, versus phenobarbital, you treat them in the emergency department and then they're done. The other thing is in this study is that it was safe. It wasn't like patients were having problems. Follow-up, they did lose some patients to follow-up because, as you might imagine, that this population may be a little bit harder to reach than some. They may sort of have housing instability or other social issues that prohibit them from following up. But basically, here they found that it was effective, but didn't lead to more sort of bounce back visits or anything like that. The question is, it's effective, but is it superior? This was a randomized trial done that looked at alcohol withdrawal needing admission. So severe-ish alcohol withdrawal. And they used a 10 milligram per kilogram bolus of phenobarb versus a CWA-triggered Ativan. So you get a score, the nurse gives Ativan. You give a score, and it's sort of protocolized that for certain scores, the nurse will give certain amounts of Ativan. And what they found, pardon me, is they looked at ICU admission, and the patients in the Ativan group needed a lot more the ICU, which is something that's important. ICU beds can be scarce. ICU care is more intense. It's more expensive. And so that could be very important. So the decrease in ICU admission was 17%, which is enormous. Now the 95% confidence interval, because this was a small study, was pretty broad. So maybe it was only a 4% decrease, could be much larger, although I would think that would be too good to be true. So probably some benefit to ICU admission. If you look at all the observational studies, they're mixed, probably because there's a lot of confounding in terms of who gets phenobarbital and who gets Ativan or another benzo. So when you look at observational studies, the randomized control trial showed as a benefit to ICU admission. If you look at the observational studies, they're sort of all over the place. And so I'm not sure whether it's more effective. It's at least effective. I think the jury is still a little bit out on how much better it is to simple benzos in terms of preventing ICU admissions or lengths of stay, because some observational studies show it's better. Some shows that it's about the same. No studies show that it's worse. So sort of in summary, phenobarb it has really amazing pharmacology if you're just looking at, okay, does this make sense for alcohol withdrawal? In addition, if you're thinking about ease of giving it in the emergency department, reaching patients in the appropriate time for reevaluation, et cetera, the duration is really good. Also thinking about patients that may be going home or to another facility, the duration is really good. It's titratable, so you don't have to switch between things if it's not, say you're giving lorazepam and it's not working, switch to diazepam. It's rare that you have to add something on top of phenobarbital. Usually just with this monotherapy, you can get most patients under control. And if you don't, then that's really severe. And it's effective. It works. There's some thought maybe it's a little bit better. I don't want to overblow all that. The last thing is, so you treat them, you want to figure out why are they in alcohol withdrawal. Oftentimes it's because of money. They can't afford to get the alcohol. Sometimes, a lot of times patients are trying to quit. They may be trying to cut down. Maybe they cut cold turkey. Maybe they've been decreasing the amount and they're still putting themselves into withdrawal. Oftentimes it's because there's something else going on. There's an infection brewing, some they're sick, they're just not able to take it in. It's really important for us to talk about, so, how much have you been drinking? What's been causing you to drink less? What came first? And oftentimes you have to get patients a little more comfortable to help sort this out. Because if somebody's just miserable and vomiting, sometimes then it's a little hard to get information. Or it could be maybe they're having a GI bleed or something else is going on. But it's really important that, when we see alcohol withdrawal, that it's not just, okay, alcohol withdrawal, treat and done and anchor on that, but trying to figure out, okay, this nausea, vomiting, abdominal pain, is it all from the alcohol withdrawal or is there something else going on? Because many of these patients may have comorbid illnesses as well. So alcohol withdrawal, identifying it, oftentimes easy peasy, very easy to identify. Sometimes it sneaks in a little bit, patients coming in for something else, or they're being treated for something else, then they start deteriorating. And then we got to ask, hey, how much do you drink? Do you drink often? Those sorts of things. Is it possible this person has alcohol dependence? Benzos are fine. I personally think phenobarbital is great, and we've been using it for about 7 years, routinely as sort of the first line at my institution. And then figuring out why are they in withdrawal? Is it just for some reason they don't have access, money? Are they trying? Or is they're sick and there's something else going on? So this is my typical pathway. If it's mild withdrawal, I'll give phenobarbital. We have a large psychiatric population in our hospital who are awaiting bed placement. So they're patients that need an inpatient sort of psychiatric stabilization period. We don't have enough beds in our state. And so they will sometimes wait for days to a week, sometimes a couple of weeks for a bed to become available. And so, as you can imagine, people might start withdrawing. So we see a lot of mild withdrawal and go orally in those patients. But, other patients, mild, start with some IV medication as well. You can give a couple doses as needed. And then if they're better, you can discharge them. You don't have to send them along with anything. If they're not better, you can give them more IV or PO until you hit that 20 mg per kg. And at that point, you need to stop with the phenobarb and consider something else. Moderate to severe, I just load them right up front. I give 10 mg per kg. Ideal body weight over about 30 minutes. So that's about 700 for most of my patients, unless they're, short or things like that, or very tall. And then they can get pushes as needed, or some orally. If they're to a point where they're better, they're just a little tremulous or something, I'll give them that orally. And then again, if I'm hitting that 20 mg per kg, I'll add on something, because obviously you don't want to keep doing something that's not working. But then I'm really considering, okay, do I have the right diagnosis? Is there something else here? Because it really should touch it. So kind of putting it together, this is when I'm treating alcohol withdrawal, what we kind of use the algorithm where I work. So that is approach. Let's see, questions.
Yeah. Sorry, I'm just scrolling. So Dr. Myers was just wondering if there are any patients in whom phenobarb should not be used, like elderly, perhaps.
Yeah, in the very elderly, it's complicated because there's no good medication, right? Like you don't want to give benzos to the elderly. So the idea is actually like risk of delirium, and the thought is that there might be less delirium. It hasn't been well studied, so there's actually not the elderly. I just go lower with everything. I don't necessarily want to give them benzos either. I just reduce my dose and go cautiously with whatever I give them. And right now, actually, we have a phenobarb recall. So phenobarb has been harder to get the past couple of weeks. So we've been using diazepam, and so I just cut my dose and go low in those groups, because either way, like I don't want them on benzos for days, because then they're definitely going to get delirious.
Question for me, people, let's say you're inheriting someone and they've been given high dose Valium because that was the choice of the previous doc and it hasn't been working, and now you want to start phenobarb. Is there a concern there for someone who's already received high dose to overlap the two medications?
Yeah, I mean, anytime you mix and match, there is concern, and certainly sort of the concurrent, like you could get, respiratory suppression. I have inherited some of those patients, and again, I will go low with the phenobarb. I'm not going to load them 10 milligrams per kilogram right up front. I'm not going to give them the 700. I might start with 130 and go from there. I think so. It's interesting when we first started doing this, we were all very scared. So this was brought into our institution by somebody who trained at one of the places where one of the studies was done. A fellow came in, he was a research fellow, and he came in and he was like, we should use phenobarbital for alcohol withdrawal. That's what we did. And we were all sort of like, that doesn't seem safe. And we had all of these concerns, and our inpatient colleagues were like, you're giving them phenobarb, they have to go to the ICU. And once we got our institution on board and it sort of became what we did, it's fascinating that the concerns have been, like, we could read the literature and know it was safe, and that even giving a little bit, but the doses we're giving are not that high that they typically cause respiratory suppression, or mental status suppression. So I'm just sharing our institutional experience because it's been interesting to see how, like, I was so concerned and I would not mix and match. And now at this point, if I inherit that patient that's been giving some benzos, I don't sit there and give them both. I just stop. I assess their mental status. I see where they are. And then I give phenobarb, because there are studies that also show that phenobarb can help reduce benzos. So they give both intentionally to help reduce benzo consumption, because the idea that is sort of borne out in the alcohol withdrawal literature is like, you want to reduce the amount of benzos that you have to give to somebody. There's delirium, it's harder to get off. It doesn't actually do anything for the GABA dependence and stuff like that. So that's sort of, I think it's fine as long as I actually physically, it's not one of those like armchair orders that I go and put in. Someone's like I'm like, oh yeah, give them another dose of phenobarb once if they're not better in 15 minutes. That's somebody I go back, circle on, make sure they're okay, see what's been given, tally it up, see when things were given, and then go a little bit lower. If that makes sense.
It's a related question from Dr. Ganoum. So some toxicologists advocate for a cocktail of benzos and phenobarb so that all the different GABA pathways are covered. How do you feel about that?
I mean, theoretically, like, it makes sense. I think that if I had super severe withdrawal, I mean, not me personally, but if I had a patient who had really severe withdrawal and phenobarb wasn't touching it, I'd give them some benzo. It's so rare. I mean, I think that there might be some places where we see a lot of alcohol withdrawal. The city where I work has a huge opioid use problem, and a huge alcohol use problem. But we see very rarely alcohol withdrawal that we can't control with phenobarb. But I think I think it's good. It's great to have stuff in your armamentarium. If it's not working, then add the benzo, because they work on GAB different ways. Does that mean propofol? I'm assuming. Yeah. Okay. Sorry, I can click on the link. Yeah, propofol is where you go if you're like end stage, right? Here's the thing. A lot of this comes down to hassle bias for me. So if I have somebody who needs propofol, who needs ketamine, they have to go to the ICU. So propofol is a great drug. It's going to help prevent seizures. But it's also like, you're running it on a patient who's not intubated. So they're going to have to go, at least where I work, to the ICU. That's an ICU bed. And again, it's just working on the GABA. So I've certainly used propofol for severe alcohol withdrawal. I haven't used it in years for patients with alcohol withdrawal. I just haven't needed to. But yeah, I mean, it works on GABA, so for sure.
Great.
All right. Sorry, y'all are almost done with me.
It's been fantastic. You can stick around for 2 or 3 more if you want, but if you want, it's up to you.
If I want. All right. I'll just go through all the talks I've ever given. All right. This talk is sort of about my area of research. So Dr. Grad started off talking about knowledge translation and implementation science, and I was never destined to be a researcher. I was a podcaster. I blogged as a med student, but what fascinated me was how I did my 4th year of med school. I went to a bunch of different hospitals, and I found people practice differently every way. They all thought they were right. Everyone thought they were right. And oftentimes that had nothing to do with the evidence. It just had to do with, that's the way we do it. That's the way we've always done it. And so I got really interested in this idea. And so this talk is sort of about some of those things. I got into research because I have pet peeves about evidence-based practices. And so you'll see that here. Research is really fun if you just tackle it from what are my pet peeves, and then trying to find science to either, see what objectively, whether you're right or wrong. All right, disclosure, my area of research is in this realm. And so I take money from a grant from our government to do research on this. August 24th, 2006, I was just graduated from college. I was in my first job as sort of a social worker for people with autism and developmental disabilities. And my life sort of changed this day. Sort of everything that I thought I knew changed. This was the day that I found out Pluto was no longer a planet, which sort of sent my entire idea of the world sort of in this odd orbit. And it turns out I wasn't the only one. A lot of people sort of got up in arms about this idea. Pluto, they sort of held on to the idea that Pluto was a planet. And 14 years later, I have a now 8-month-old. This is his nursery. And you can see that I still haven't given up on Pluto. My other children made paper mache planets, and they even made Pluto. So we have a hard time letting go of things that we've initially been taught. This is a 14-year knowledge translation gap for me, a hard time getting rid of things. And it's not just sort of in the realm of astronomy. It even has to do with the foundation sort of emergency medicine. So thinking about basic life support, advanced cardiac life support. The year was 2009. I was a first-year medical student, and I learned the ABCs of medicine: airway, breathing, circulation. Somebody codes in front of you, ABC, airway, breathing, circulation. It makes sense. It's catchy. I know my alphabet. So in a moment of crisis, I could remember ABC. The next year, I had just recertified. So I wasn't due for another couple of years. So it actually took me, embarrassingly, a couple of years to find out about this. Thank goodness for blogs and podcasts. But they basically took the alphabet and rearranged it. Like, what is that? CAB, that's not catchy at all. Circulation, airway, breathing. It turns out that what we were doing wasn't supported and we needed to change. Circulation, airway, breathing. But it actually takes time for people to do this and to rearrange this practice. To this day, during a code, people still often just go for that airway right up front. They spend time on that airway instead of just focusing on compressions, feel compelled to establish an advanced airway. And this gets to the point of a knowledge translation gap, which is the time between when we know we should do something, when evidence supports it, and we are actually putting that in practice in most places. And this gap is estimated to be 10 to 17 years. Obviously, in COVID, we saw that for many things shortened down immensely. But the knowledge translation is just about knowing what you're supposed to do and then actually doing whatever it is that the evidence says. So you know what you're supposed to do and then you do it. And so it's not that hard, right? We all believe that if we only knew the evidence behind something, we would do it. It's far more complicated than that. So first of all, knowing is super hard. There is so much out there. It's estimated that the number needed to read, so the NNR, this is actually a statistic, but the number needed to read. So how many articles, journal articles, do you need to read to find one that is relevant to your practice that might change it? 20 to 200. And I'm probably characterized by many, despite how cool I might appear, as a super nerd. I love to read the literature. It's like my superpower. It's what I do in my free time. But I can't read 20 to 200 articles to find one that might change my practice. It's hard. And if you're a full-time clinician working, you've got a family, you've got hobbies, this is really difficult. Knowing what to do is hard. But then the problem is half of what you know is probably actually wrong. There was a Harvard dean that said, half of what we're going to teach you is true, half is not. The problem is we don't know which half is which. We talk about a lot of things with a degree of certainty in medicine without knowing that a lot of what we do is based on really poor evidence. So what happens is a lot of that is or will be overturned. This is an article, A Decade of Reversal, and they looked at 146 medical practices that had been like sort of overturned with the evidence. And in 40% of the cases, these like standard of care practices were reversed in other studies. So you think that something's standard of care, well, another article comes out and says, nope, 40% of the time. And this is just in 1 decade of published studies. Another group reanalyzed randomized clinical trial data. So they took practice-changing clinical trials and ran them through a different statistical machine. So same data, just did some different tests. And they found that when they did that, the standard of care was reversed in over 1/3 of cases. So about 1/3, maybe not a half, but 1/3 to 40% of the time, within a decade or so, what we believe as a standard of care practice may turn out to be not what we think it is. So knowing is hard. There's so much literature out there. And it's not so much that researchers are sneaky, sure it is. We slice and dice stats certain ways, whether we should or shouldn't, we definitely shouldn't. But all these things lead to some sort of medical reversal. There's publication bias, certain trials get in. Maybe statistical methods have evolved over time. Treatments have changed, adjunct treatments have changed. What happens is what we think we know becomes overturned. Knowing is hard, but doing the right thing is actually harder. Again, we think we would do the right thing if only we knew. We would practice the evidence-based approach, but changing what we do is super hard. I'm sure y'all have all gone to the bathroom this morning. Hopefully after you went to the bathroom, you washed your hands. We know we should wash our hands after we use the bathroom. Same thing in medicine. We know we should wash our hands. However, in this study, they did something kind of creepy. They were at a surgical conference and they watched people in the bathroom, which is kind of, I'm not sure exactly how they got consent and all of those things, but they basically watched surgeons in the bathroom, and they found that 1 in 5 surgeons at this surgical conference didn't wash their hands or wash their hands after using the bathroom, but they found that, of course, compliance was 100% in women. So there's that. But we all know we should do that. What about in the emergency department? This is a study from Canada in which they looked at hand hygiene, and it was an observational study. So they watched people at various times when they should wash their hands or clean their hands, going in and out of a room, touching a patient, handling body fluids. And you'd like to say, right, we know we should all wash our hands. We've known this for a couple hundred years, that you can help prevent mortality if you're doing surgery, but even it's just like good practice to engage in hand hygiene. So they wanted to know, how often were people engaging in hand hygiene at appropriate times? 29% of the time. That's kind of abysmal. And then the problem is that it was only 26% after touching bodily fluids. So oftentimes people had gloves on, but still, like, gloves aren't perfect, and you would still think you would wash your hands or put some of that foam on afterwards. We're still have a huge knowledge gap with regards to hand hygiene. And it's been hundreds of years that we've known we are supposed to do this. We know it, it's just very hard. Maybe I didn't touch the patient that much. Maybe my hands are dry. Maybe there's no alcohol scrub in this room. We have all of these different excuses, but we still just can't do it, even though we know we're supposed to do it. And this is because knowledge translation is hard. And hopefully that hand hygiene example sort of demonstrates that. So what I'm going to do now is I'm going to try to help y'all kind of figure out ways to slay this prehistoric practice so you're not a dinosaur. And a lot of this comes down to what I call unlearning. You must unlearn what you have learned. I think that this is one of the really keys to knowledge translation, and why it's so hard to to change our practice in terms of the action, even if we know we should do something. So learning is different than unlearning. And what I want you to do is, I can't see you on video, so I don't know if you're actually doing this, but what I want you to do is take your hands up like this, put them up in the air like this, and then clasp them together. Okay, which finger is on top? I want you to look at it and think about it. So my right finger is always on top. Most people will have their right or their left. There is some subset of odd people, I'm just going to call it what it is, who do this. Bless your hearts. I don't know how you do that. I can't stand that. Okay, so your hands are like this. Now take them again, put them up in the air, and then do it the other way. And for me, I've given this talk several times, but it still feels weird to do that. Like I never naturally default to that. If I'm not thinking about it, I'm putting my hands together, it just feels weird. When I do it, the hairs on the back of my neck kind of prickle up, and I can't do it without thinking about it. If you just sit there and you do it a couple times, you'll get more used to it. It feels more normal. But if I ask you tomorrow to do the same thing, you're going to default right back to where you were. This is my analogy for learning and unlearning. Learning is our default. We're good at it. We've been doing this for so many years. We did it in college and in med school and in residency, you're doing it. In fellowship, I did it. Like, we're really good at cramming stuff in our brains. It's why one of the reasons we were so good at knowledge translation during COVID. We were hungry. We didn't have a pre-established practice pattern. We were hungry for information, and we could stuff more stuff in. Unlearning is harder. It takes thoughtful effort, and we're going to default back to what we were originally doing. To change our practice, we have to unlearn something, and it feels harder. We're just not as good at it. Learning is habitual. It's comfortable. Unlearning, it can be forced. It can be awkward. It's not our default. And part of this is because we have emotional bias. We think about things and we think our knowledge saves lives. We have some level of ego attached to this, even if we don't think we do, right? We can't think about, man, all these years I've been doing the wrong thing. Like, obviously that kind of like hurts a little bit. We get emotionally tied to our knowledge. So these are sort of like the stages of unlearning. We're going to go through this a little bit. So first, if I tell you a practice that what you're doing is not evidence-based, and I'm trying to urge you to switch practice to something else, you might feel shock, denial, anger, depression, and eventually some acceptance. So for example, going back to the Pluto example, these are all letters to Neil Tyson deGrasse. So what do you call Pluto if it's not a planet anymore? If you make it a planet again, then all the science books will be right. These are letters kids wrote. Why can't Pluto just be a planet? Sort of this like denial, like it's just a planet. We see the same sort of thing in medicine. So like thinking about airway, breathing, circulation, people sort of like in denial, like I'm just going to go ahead and intubate this person anyway. Deep in your heart, is Pluto still a planet? I'm just going to, slide that in there real quick. Then there's sort of this anger phase as well, that people may experience, sort of like, well, I'm just going to do what I want to do anyways, and sort of get angry about it. It's when we sometimes have these sessions with our pre-hospital folks, they really like to intubate. It's really fun. And so sometimes when we're like, doing these trainings and it's focus on your compressions, focus on that, like you can stick in an LMA or a King airway or something like that. That has taken a lot of time because they get angry. Like, you're taking this skill away from me. It becomes about them, not about what the evidence says. And people get depressed and sort of nihilistic. Resuscitation is useless. Nothing is going to work. Why do these things at all? And then sometimes people can get over it. It's sort of that acceptance phase. For example, this letter says, we just have to get over it. That's science. We have to learn. And that's sort of where unlearning comes into play. Unlearning, I like to think of sort of like yoga for your brain. It's just becoming more cognitively flexible and understanding that things change and it's not our own deficit, and sort of being open and really looking for that and seeking it out. So often we look for things to confirm what we do, not really looking for things that will help us become more flexible. So it just requires some degree of cognitive flexibility. It's also easier with repetition. So when oftentimes, the more times we're told something, the more times we repeat it. So I'm going to tell you things today that you've probably already been exposed to, whether it's about phenobarbital, whether it's about LGBT care, whether it's about PEs. The more times you encounter that, the easier it's going to be to unlearn whatever it was that you were thinking or had done previously that may not have the evidence base behind it. It's also easier with earlier exposure. So it kind of goes back to repetition. The earlier in training or the earlier you encounter something, the more time you have to warm up to it. If you're early on in training, it's going to be a lot easier because you're more easily able to be influenced. It's also facilitated by a diverse community of practice. So it's like going to work out. It's easier for many people to work out if they have people to uplift them or support. You'll find people like in the CrossFit community get really excited by having people around with them, people that are sort of on the same page. I'm not going to say the word cult, but somewhere. But with unlearning, it's sort of the social media platforms, Twitter, blogs, and podcasts have sort of facilitated this. When you see what other people are doing and you have interaction with people, I'm like, oh, not everyone gives benzos for alcohol withdrawal. Some people do phenobarb first. That's how we were first exposed to it at our institution. Or even digital blocks. So for example, I'm trying to change the culture at my institution of doing digital blocks that involve going on either side of the finger and instead doing just the single digital block here for these 4 digits. So a lot of times encountering people who have different practice patterns, a diverse community, is helpful. And so foam sort of tackles a lot of these. You get early exposure. You've got the cutting edge, bleeding edge people that'll be introducing ideas well before they are ready for prime time. So maybe then's not the time to adopt it, but you get that exposure. You're able to start thinking about it, considering it. And then what happens is oftentimes it's repeated throughout. As evidence amounts, becomes the repetition comes there. And then also exposure to various practice patterns through foam and other sort of aspects like social media, or even just talking with people from different institutions. When you are exposed to different practice patterns, you're able to become a little more flexible. And so we're going to go through a little workout here. And these are some examples sort of from my personal life. So this is one that I think is important. So you've got a patient who has chest pain and you're worried, I don't know, aortic dissection, is it a PE? But what we've been told for years and years and years, thankfully this has changed over the past few years, is that IV contrast kills the kidneys. There's this thing, contrast-induced nephropathy, and it will result in renal impairment and renal failure in your patients. And so for a long time there were GFR cutoffs or creatinine cutoffs to get IV scans on patients. And oftentimes, we worried, we were like, well, I'd like to get this scan with contrast, but their renal function, maybe I need to get a different type of scan, maybe I need to wait. So for example, I was introduced to this early on. In 2013, there was a blog by a guy, Ryan Radecki at EM Lit of Note, who talked about contrast-induced nephropathy and some of the literature behind it. There's another blog post from Palmcrit in 2015. Do CT scans cause contrast-induced nephropathy? So I was exposed to it early and then sort of repeated. And then in 2017, there was this emergency medicine cases podcast on this as well. And just again, my bias here. So I published a meta-analysis on this in Annals of Emergency Medicine sort of during this time as well. It's sort of inspired by this early work. So you can see repeated exposure early on over time. And it turns out this whole idea of contrast-induced nephropathy came from this case report submitted for publication in 1954. And it was acute anuria following intravenous pylography in a patient with myelomatosis. So this is interesting because this person had a very prolonged stay. They were admitted, they were pale, they had like their organs, they had very like hepatosplenomegaly, and they got various workups in the hospital. And they said their observations call upon us to be cautious of using IVP in patients where there's a possibility of the presence of myelomatosis. Okay, fair. This was a complicated case with many confounders, probably some baseline renal disease, maybe some allergic to contrast. This patient had multiple tourniquets on over the course of time due to other medical issues. And they had other interventions, and they were baseline very, very sick. Also, this is a single case report. What happened was this case report, which sort of was judicious, said, be aware of this one specific test in patients with this disease. Well, that led to uncontrolled studies where people basically said, okay, we're going to look at the incidence of a creatinine rise or acute kidney injury in patients who get a contrast-enhanced CT scan. Now, what's the problem with doing that? The problem is there's no comparator. A group of people of the people that you do a contrast-enhanced CT scan on, oftentimes there's something baseline going on, whether it's sepsis, whether it is their PE or something that's making them ill, that some of them are going to have acute kidney injury for a variety of reasons, whether it's their disease process or the medications they're given, all the antibiotics that they're given for their sepsis. So the issue there is nobody thought, we need a control group here. And so these uncontrolled studies led to essentially uncontrolled fear and this idea that you're destroying kidneys with contrast. So we did this meta-analysis published in 2018, in which we only looked at studies that had a group who also got non-contrast CT scans. So it's not a perfect comparator group, but you've got the studies of contrast-enhanced CT scans and non-contrast enhanced CT scans. So there's probably some difference. There may be some selection bias there, fair. But overall, you can see here that we didn't find anything to demonstrate that there was more harm associated with contrast. In fact, the point estimate favored a little bit on the other side, but obviously it's not like contrast is protective, but we didn't find any signal of harm there. Same thing with mortality. Didn't find any signal of harm for mortality or renal replacement therapy. Even when we broke it down by different subgroups, we did not find a trend towards harm with contrast. So basically, what we found in other studies, there was a recent study published that used some fun methods that looked at like the D-dimer and PE studies that again shows that our fear about contrast and renal function is far overblown. And so fortunately, recently, iterations of manuals on contrast media from radiology and kidney foundations have said this is probably overcalled, that maybe you need to worry in patients with a GFR less than 30. We just don't know because we don't have the data on that. So the unlearning pro tip here is when you hear something that contradicts your beliefs or practices, think about what was your original evidence based on? Why do you practice the way that you do? Why do you believe what you believe? Is the evidence that you see now higher quality? A lot of the things that we do come from things like this, a case report that ends up getting perpetuated and blown out of proportion by uncontrolled studies. So when you see something that contradicts what you do or what you think back to what underlies your practice in the first place. We're going to talk about needle decompression here. This isn't something we do much in the emergency department. It's done somewhat in the pre-hospital setting. Now, you can toss in the chat, where would you decompress? If you are teaching a paramedic or pre-hospital person, or you're doing it in your emergency department, where would you engage in needle decompression? A, B, C, D, E, F, G, H. Thoughts? H. Where you put the chest tube, safety triangle. All right, one vote for A. They're pandering to me. They're a plant. Yeah, y'all are right. Can't fool you. So H. In 2017, the ATLS 10th edition said 4th or 5th intercostal space mid-axillary line, or H. And this is after years of knowing that this is probably going to be the place where it works the most. So in 2012, I saw this tweet. It said, stop putting IV cannulas in the second intercostal space. So linked to some studies showing that it's more likely to fail in that place. And this is because the mid-axillary depth is going to fail sometimes, but it's going to fail less than the mid-clavicular line. And that's because the depth of the chest wall at the mid-clavicular line tends to be more than at the mid-axillary line. And so they both may fail, but your chance of success is going to be higher at the mid-axillary line. 2013, another blog post that reviewed again that saying you're going to need a really long needle, and even then you might not reach it, because these studies, and oftentimes they would look at the chest wall thickness on CT scan and measure it, so it's sort of like a proxy, and see it might fail. So the second intercostal space, ATLS even says now greater than 50% will fail with a 5-centimeter needle. So you're looking at a long needle and thinking that half the time that still may fail. And so this just gets the idea of space repetition. Over time, it's easier for us to remember things the more often we repeat it. So you're more likely to retain things over time. It becomes easier and easier the more often, and you kind of retain it. Same sort of thing here. The more you're exposed to something, the more likely you are to actually consider it, give it some sort of authenticity in your head, and be able to change when the time comes. This is another example here. So cardiac arrest. What do you do? What are sort of basic principles in the cycle of BLS and ACLS? I'll guarantee you, if your shop looks anything like mine, at some point a nurse will say, you're due for a pulse check. And every single time, I can't help but sort of roll my eyes a little bit. And I usually talk, if it's my resuscitation, I talk at the beginning of the time, how we're not stopping to do pulse checks. Turns out we are terrible at pulse checks. How many of you think you can recognize a pulseless patient in 10 seconds? Whenever I give this talk in person, people raise their hands like, yeah, totally can. Except for we can't. We're not very good at it. Only 2% can really recognize a pulseless patient in 10 seconds. We feel and think and feel and think. And obviously, we have this bias. So if you ask me, I think, well, yeah, that's 2%, but I'm better. Like, I've been a doctor for a while, I'm good at it, and I'm just naturally skilled. So like when I tell people about that, it's like, well, I'm different. I've been doing this, I can do it. But thinking about this, actually, like, maybe I'm not perfect. So when I first heard of this on a podcast, I was like, oh, I can definitely do it. And then I started paying attention and realizing maybe there's something to this. So with pulse checks, they've done this, and it's interesting. They'll put people on ECMO that's either pulsatile or not, and blind people to what type of ECMO they're on and ask them to palpate. And they found out that accuracy is only 78%. And you would think that like it would be 100%, and it's not. I first heard about this in 2013 on a podcast when I was driving on a rotation at the end of med school. Heard it again in 2015. And as often as I've heard about this, and as often as the American Heart Association guidelines, and this is from 2015, 2020 also has the same thing. Nowhere in here does it say stop for a pulse check. It says, is the rhythm shockable? 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 Because of the difficulties with pulse assessment, interruptions in chest compressions for a pulse check should be minimized during the resuscitation, even to determine if ROSC has occurred. The issue here is that there are so many other ways to determine if ROSC has occurred. And is ROSC going to occur if a patient has asystole? The answer is no. If a patient has ventricular fibrillation, do you need to worry about ROSC, or do you need to defibrillate them? You need to defibrillate them first. So there is essentially no reason to be doing a pulse check during the resuscitation. We've got other means, we've got other proxies, we've got end-tidal CO2, we've got ultrasound, we've got other things. I want to play this game. All right, I'm going to get ready to play in the chat. I'm going to need your answers here because I am going to be timing you. I've got my stopwatch here. All right, so get ready. This is a quiz. The quiz is, what is the rhythm? Type it in the chat. All right. Good. Y'all are good. Less than 10 seconds. All right. That was 7 seconds until the first one Y'all are on it. All right, y'all ready? You know the game now. What's the rhythm? Okay. All right, we didn't even make it to 3 seconds. Y'all got it. Rhythm. Okay. All right. It needs a shock. Great. Yes. Y'all are right. Again, 3 seconds. All right. What's the rhythm? Yeah, it's Brady. All right. What's this rhythm? Just kidding. All right. So the point of this the point of this exercise is rhythm checks are really quick. Rhythm checks are really quick, way quicker than feeling for a pulse. We know it, and that gives us something actionable. If somebody's in asystole, we don't need to check for a pulse. If they're in VTAC, if they're in VFib, we need to shock them. And sometimes if you see a rhythm, well, then you can pause and you can look for pulse, you can look for other markers. So this is just to say rhythm check is really, really quick. There are other ways: ultrasound, arterial line, end-tidal CO2, pulse, and blood pressure to determine if ROSC has occurred. So the learning pro tip here is check yourself and check your ego. We often see statistics and think, oh, we're just better at it. All right. I think this might be my last one. So you have a patient who has a peanut allergy, and they ate something that was prepared by somebody else. Maybe somebody thinks they used some like nut milk or something in it instead of regular milk because that's all they had, and they start to swell and they start to itch. What are you going to do? Epi. Y'all are so right. Yes, the treatment for anaphylaxis is epi. Anything else? Are y'all good with epi? Sticking with epi? Sticking with epi. Love it. Adjuncts if they need it, right? I love it. Adjuncts. Y'all are on board. So antihistamines are adjuncts only in anaphylaxis. We know this, right? It's still something that people will be like, oh, I actually had this on my last shift, is a patient came in with that exact story, except for she was allergic to all tree nuts and thinks it was somebody had put cashew milk in buffalo dip. And I was like, who puts cashew milk in buffalo dip? But also the nurses and techs were working to get an IV line. And I just turned around. We have pre-made packets with epi. And I said, no, I want you to do this instead, and handed the packet. We get so caught up in these other things and forget the treatment for anaphylaxis is epinephrine. Other things, they may work, they may help in certain things, probably minimally and only to help symptoms. Now, antihistamines are commonly given to patients with anaphylaxis and urticaria. The issue is that almost everyone will reach for Benadryl, and maybe it's because what you have. But if you were to talk to patients who suffer with allergies, initially they'll say, well, I took Benadryl as soon as this happened. And I'm like, first of all, you need to take your EpiPen if this happens. Second of all, throw away the Benadryl. There's something else better. Things like cetirizine, your second generation H1 blockers. Benadryl is out. And this is because it's sedating. It doesn't work any better. It's definitely not the treatment for anaphylaxis. It just may help people be less itchy. It helps reduce some of the histaminergic responses, but it doesn't actually treat the anaphylaxis. It's not going to prevent their biphasic reaction. It's just to make them feel better. And Benadryl is sedating. It's not good. Basically, all the societies have come out saying, stop using this. This isn't a new thing. This is a QR code to some recent links. But basically for urticaria and for anaphylaxis, they say, yeah, if you're going to use an antihistamine, use a second generation antihistamine. There's almost no role for Benadryl now, not for headaches, not for anaphylaxis, not for urticaria. But it's still what people go to. It's still in medicine cabinets around, that people have, and it's what they reach for. It's like, oh, I'm having an allergic reaction. I have hives. I'm going to take some diphenhydramine. And this has been sort of years in the making of guidelines saying second generation, second generation, second generation. And this is just the last pro tip here is just beware of inherited practices. When you ask people why they take Benadryl, it's just because it's what people told them. It's what everyone says. It's what everyone does. But for me, if you give me Benadryl, if you give me half of a Benadryl, I will be out for the next day, and then I'll wake up and I'll feel terrible. And so there are downsides to what we do. And there are upsides, which are, you might treat patients so that they can drive home or things like that. But basically beware of doing things just because it's what everyone else does and it's the way that things done. It's hard to stick out sometimes, but it can be important. I'm going to skip this one because I already went over it, but basically, that PEs, we talked about, there are many scans that may be false positives for PEs. And the issue is it's harder to unlearn to stop a practice than it is to add something. So if it's harder, when we take away a practice, when the evidence says, hey, you need to stop doing this, that for us is harder than to add on. If I say, hey, you need to order a lactate at all these times, we can just start ordering a lactate. But if I suddenly want to take that away, for some reason, we have a really hard time. And so that's something to think about when you're doing something is, am I just having a hard time because I'm stopping something? Knowledge translation, it does require work and it's harder than people think. If y'all have any questions about any of the talks today or want any of the references, didn't catch a QR code or something like that, feel free to reach out to me. Happy to answer any questions.
Knowledge translation, it's such a huge issue, but it's so complex. Also, there's so much politics involved. You try to do the right thing, and it's not only between you and the patient, it's between you and the nurses. If you're doing something that is not what they're used to, it's between you and other specialties. I mean, I know for this the contrast related issue, I've been telling techs, radiology techs for years, I was saying, 5 years from now, when they were refusing or questioning me wanting to do a CT with contrast, I would tell them, 5 years from now, we're not having this conversation. You're going to see. But it's a struggle to wait those 5 years. It's hard to do the right thing. And it's easy to say. And then even if you're dealing just with your own department, there are clinicians that are so entrenched in what they're doing. And you try so many different types of interventions to try to get them to show them the evidence, and you just see it over and over. It's still hard. They still believe they're doing the right thing because of their N of whatever ones, twos. They only see that patient in front of them and think that what they're doing is better than what the evidence shows. So I'm not sure what to say to you, what the question to ask you about how to get around that. It's just that it is a struggle that that we're still learning how to best and deal with it. And I think was it called intervention science? Is that the term you were using? So is that your own term, or is
implementation
that,
science?
An actual thing where we're implementation science, not intervention science, right? So that is actually a thing now. Is it an area of study academically? People doing graduate programs? Yeah.
Yeah. It's a big field. There are international conferences about it. Basically, it's evidence-based ways to get people to do what they're supposed to do. So basically, you have an evidence-based practice. It's I'm not going to say how do you manipulate, but how do you get people to change what they do, acknowledging that it's so hard. So it's not just in medicine, public health, and other things. It's like anytime you have an evidence-based practice, how to put that in. But I get what you're saying. It is really hard. And that's why, when I was a med student and I had no power, I would often tell my attendings or my senior residents, I would say, oh, well, as you know, blanket all did this. And so then they'd be like, oh, of course. Yeah, I know. They would be like, oh, no, I didn't know that. But I would try to be subtle about it. But the more times I would say that and repeat it, and I'd be like, oh, I understand that you don't do that. This is another way. I also preface a lot. So I talk to the nurses a lot, and I'll say, you're going to hear in me this resuscitation that we're going to pause to do rhythm checks. And here's why. And I'll tell them. And in my off time, I spend a lot of time talking with them, not off time, but when I'm at my computer charting or I should be charting, and instead I'm talking to people and then I'm catching up on charts the next day, is I'll talk to them and run them through some of those things about why I asked for the cetirizine, even though in our hospital we only have it in liquid and it's a little bit more of a pain, or why they can put an IV in a patient with who's had breast cancer and their lymph nodes removed, why they can put an IV in that arm, things that are like these inherited practices that the evidence doesn't stand up to. I try to take that time prophylactically, and then I'll touch base with them after and be like, hey, I know I did something a little bit different. I wanted to explain to you why. Or I'll touch base. I'll do the same thing with colleagues too. Sometimes I used to, when I was a resident, put papers on the surgeon's desks. Anyways, I no longer do that now, but yeah, it's hard.
What kind of feedback do you get when you drop a paper on a surgeon's desk?
Well, I was known as the agitator. I still sort of am, as like I get the residents on board. And what's interesting is I run our journal club, and I choose my papers based on what I hear the residents say. Either we see practice pattern variation around this, or I see evidence opportunities for where the evidence and our practice doesn't align. And so the residents are what help keep us honest, because how often do two attendings practice and talk about their practice patterns together? Not very often. We just don't have a lot of overlap. And I'm a nocturnist. I work almost exclusively night shifts. So I very rarely, I have one other attending working in a different pod, but we don't commonly work together. And so, the residents are really how I help move people forward. And they're the ones that'll be like, hey, I heard this. And I'll be like, no, that's crazy. That's on the bleeding edge and there's no literature. Let's not do that. But it primes me to think about it. And they're also who change other people. The surgeons, they expected it from me when I did that. They knew what they were getting into after meeting me.
I was curious, being on the leading or bleeding edge. We had a talk a few months ago from a few FOAMed people here, like EM cases and Canadian EM, and there was discussions about incorporating FOAMed into the residency education curriculum. Just discussions about it. Like, what do you think about that?
I think that it's a necessity. So I think for a couple of reasons, you need to teach people how to consume it, because residents are consuming it regardless of whether you want them to or not. But if you teach them how to interpret things, for example, I love journal feed. I'm not sure if y'all are familiar with journal feed. It's great. However, oftentimes I think they get articles completely wrong. And so what we'll do, if, for example, there was this sterile water injection for low back pain that they said was a rigorous trial. And so I saw that my residents were talking about it. And so we went through and we talked about that article in Journal Club. So there are different ways to incorporate it. That's one way, is when I hear them talking about something that maybe isn't quite right, because there's a variety in terms of like what people think about different resources. We'll bring that up and into, but I think that it absolutely needs to be included because people are consuming it, but more importantly, because how are people going to learn once they're done with residency, right? How are they going to, they may go attend some conferences. A lot of people are going to continue to read blogs or podcasts or Google things. And so teaching people how to find things that are reliable, things to look out for, I think it is imperative and critical if we want to teach people to truly be lifelong learners.
Awesome. Now we're working on we don't have a plan yet, but we're working on incorporating it somehow. All right. Any other questions before we call it a morning?
I have just a quick question. I mean, I know you kind of touched on it, sort of you said you were putting journal articles onto surgeons' desks, but how do you how would you recommend that a residents sort of approach that with their staff? Like occasionally on shift, I'll say something like, oh, is that evidence-based? But I very carefully pick which staff I sort of say that to. And I've been called, I think one of my evaluations called me argumentative or something like that.
Oh, I feel you. Yeah, no, I'll tell you, I got an evaluation as a med student that I was too passionate and needed to like relax because I was interested. And it turns out that some people perceive inquisitiveness as challenging, right? You're challenging somebody and there's this hierarchy. So you do have to be careful in some way. Sometimes I'll play dumb. I can't really do that anymore, but I'd be like, oh, so my understanding of the evidence of, and I try to have on file, people believe you if you have names and dates. So like what I would do is back in the day, I had this like little notebook, but now everything's like digitalized, but I would like remind myself of things so that I would have it right on hand and I could go to it. And I'd be like, oh, well, this article, Legal et al., if I'm talking about like pulmonary embolism or something, Annals of Emergency, internal medicine, they found that whatever. Tell me about your approach. Like, how do you incorporate that evidence into your practice? And so I would ask them questions, not like challenging, like, hey, why do you do that? But I'd be like, hey, I've read some studies that when you add lidocaine to Maalox, it just makes it taste worse. And it doesn't actually improve pain scores. So can you tell me a little bit more about why you would recommend that I do that or something? And because sometimes there are things there, like, right? Sometimes there are reasons to do things other than just what the evidence says. For example, I'm going to give that PPI in a patient with GI bleed because, or like the other day, I gave glucagon to somebody with an esophageal food bolus. Did it work? No. Did I think it was going to work? No. Did I do it because that's how I got GI to come in? Yes. And I gave it to them so I wouldn't have to wait 30 minutes because I knew when I picked up the phone that they would say, well, give them glucagon and then call me back. I didn't tell them that the nurse was giving the glucagon currently. I just said, oh yeah, we've given them glucagon and it hasn't worked yet. And so they said, okay, we'll come in. But sometimes we do things that aren't evidence-based because we have to, and those conversations aren't for in that moment. They're to kind of get your institution on board. There are some things that are important to have in the moment, and then there are some things that are just larger practice patterns that are the battles that we fight, QI projects and things like that, or trying to get like a force on board to change an institutional practice pattern. I don't know if that helps.
Yeah, no, I think that's helpful. And I've definitely sent some staff, like journal feed links and stuff like that. I know Dr. Grad knows my involvement with that team, so.
Great. Yeah, I was wondering if Nick was going to speak up because he's a contributor to journal feed. So, so I was anyway. Yeah, if you want to, there's a comment if you want to actually just read in the chat from Dr. Tremeniani regarding glucagon.
Yeah, I mean, right? It might work sometimes. It might not work other times. Yeah, I mean, sometimes it's right, like jumping on your heels. What does a headache, looking at, sometimes things will resolve on their own too, and sometimes not. So yeah, glucagon's interesting. I've actually had zero luck with it ever. Out of all the boluses, and I give it to every single one. But it's interesting that sometimes also there's that confirmatory bias. It works one time, it works another time. You're going to keep giving it. And like, I'm sure it does work in some proportion of patients. Otherwise, we wouldn't have started giving it. I think most patients probably will need an EGD at some point. That's interesting.
Alrighty. Okay, well, this has been a great morning. Thank you so much. And thanks to Dr. Grad for organizing this. Hopefully we'll be able to see you as as things with COVID go back to in person, maybe these opportunities won't present as easily, but thank you so much for being present with us.
Thanks, Shaw. I really appreciate the opportunity, and thanks for participating when I asked for it. Really appreciate it. Take care, y'all.